Well, hello everybody and good afternoon. I'm Jackie Smith, Chair in Common of Barking, Havering and Redbridge University Trust and Barts Health, and I'd like to welcome you to our 2022 BHRUT Annual General Meeting, which is my first as Chair. And I'm joined today by my board colleagues, both executive and non-executive directors. I joined BHRUT last October as Chair, and I knew that I was joining at a time of real challenge from the pandemic and its impact on those waiting for treatment and on our staff, to the need to get BHRUT onto a steady financial footing. I've really enjoyed getting to know the Trust and particularly meeting staff. Their dedication and expertise is impressive, and I'm looking forward to working with them and with our partners to continue to improve services across all our boroughs for our patients. Today's meeting is an important opportunity to reflect on the many achievements and challenges over the last year, with a presentation from our CEO, Matthew Traynor, focusing on that. Further details are provided in our annual report and quality accounts, and links to those are attached to the agenda. After we've received a presentation from Matthew and a contribution from Shane, there'll be an opportunity to ask questions, and a presentation. There'll be an opportunity to ask questions. If you've got questions, please can you put them in the chat, which you can access through the voice bubble, at the bottom of your screens, and I'll then ask you to ask your question and we'll get the appropriate director to answer it. So by way of introduction then, it's been a tough couple of years as a trust navigating our way through the pandemic. It's worth remembering that at its height, we had 515 inpatients. We're now around the mid-teens, so enormous progress, but the impacts of the pandemic sadly live on. They live on in the people waiting too long for treatment, in the impact on our staff, and in the health inequalities that the pandemic emphasised. Our staff did a tremendous job throughout. Just to give you some context, in 2021-22, they administered 122,999 COVID jabs. They carried out 536,185 diagnostic tests, and they performed 15,299 planned surgeries. Many of our local partners and the politicians that I met when I arrived as Chair of BHRUT told me about their concern for the Trust and its services, in particular that the collaboration with Barts, which I'll talk more about later, would strip investment and attention from Queen's and King George's. But I've actually been struck by the huge investment that we've made in all our hospitals to improve services across our boroughs. An additional £5 million for further improvements to our enhancements to our paediatric ED at King George Hospital in Redbridge. 11.5 million on our intensive therapy units for patients needing critical care at both Queen's and King George Hospital. And we have state-of-the-art diagnostic equipment in all our sites, with our latest additions including a biplane angiogram machine at Queen's and a new CT scanner at Barking Community Hospital, where we're looking to build a dedicated diagnostic centre for patients to access a range of tests and scans under one roof. That investment in diagnostics will support the work our teams are doing to reduce waiting lists. And you'll be hearing from Amalesh, our Divisional Director of Surgery, and some of his colleagues about some of their fantastic innovations later in the meeting. It's fair to say the year ahead will be a challenging one, and one in which we'll be working within an extremely tight financial envelope. And this is where being bold to innovate and to do things differently will come ever more into its own. It's clear to me that our patients' needs don't stop or start at the doors of our hospitals, and to do the best for them and to make sure that we're spending every pound as effectively as possible, we need to look outwards to our partners in other NHS bodies, in local authorities, and in communities themselves. The changes that will help to bring closer working between health and social care are emerging in the North East London integrated care system, which became statutory this summer, while our collaboration with Barts Health provides an engine room for delivering real changes for patients. So we'll be focusing very much on partnership working through our borough partnerships, taking real action to level up the playing field for all our communities, bringing health organisations and local authority services closer together, which also means that we've got a genuine opportunity to look at the wider determinants of good health, which we know impact significantly on health services, and think far more holistically about our residents and their individual needs. One of the reasons I was so excited to take on the role of Chair in Common of BHRUT and Barts Health was the potential that comes from our two organisations working in close partnership. And we're starting to see that deliver tangible benefits. We're working to tackle waiting lists so our patients can access the care that they need as quickly as possible and as close to home as possible. And we're sharing best practice in urgent and emergency care to ensure that all 5 A&Es across the two trusts are seeing patients as quickly as possible. And there are other benefits of joint working, such as our green plans, which we've worked on together, taking our responsibility to our communities seriously. Importantly as well, by working together, we'll reduce variation in access to care, reducing health inequalities for all our residents. The success of any collaboration stems from the right leadership, and I'm delighted that we've recently appointed Shane Degaris as Group CEO across Barts Health and BHRUT, and Matthew Traynor as Group Deputy CEO. And I'm also delighted that Matthew will continue at the helm of BHRUT. One of the challenges that has been faced here in recent years is a churn of senior leaders. Shane, Matthew and I are all substantive appointments. We're here to see the job through. So before I hand over to Matthew to talk about the last year, I'd like to finish with some thank yous. To my board colleagues for your support, your leadership and your genuine desire and commitment to make BHRUT the very best it can be. To our staff, without whom we would not be able to do what we do and who work tirelessly to provide our patients with the best care possible. To our patient partners and volunteers who dedicate so much of their time for free to support staff and patients alike. To our charity for helping us with those added extras. And last but not least, I'd also like to extend our thanks to partners across our boroughs and across North East London, with whom we will continue to work to do the very best for our patients. So let's now move on to Matthew, who will be looking, as I said, at our achievements across 2021 and 22, and also looking forward. Matthew, thank you.
Thank you very much, Chair. And I think I've just got 2 slides here, which we'll run through, but it's going to be mainly me talking to these. So next slide, please. Okay, I'm Matthew Traynor anyway. I'm Chief Exec of the Trust, and I've been with us for just over a year now, actually. And I have to say I've thoroughly enjoyed being part of the team at BHRUT. There's a fantastic atmosphere around the place, and undoubtedly some serious challenges to deal with. But the thing that makes it worthwhile is that, you know, the colleagues that you work with, and I can see a number of them on this call today. And that's really the heart and soul of how we're going to drive the improvements that we want to see here. It's by really making the most of those real strengths we've got within the Trust, but also across the broader North East London patch. There's been a couple of things that we've been looking hard at since I got here. First was strengthening the top team. And as the Chair said, this Trust has suffered from a rapid turnover of chief executives. It was very striking coming here as the third chief exec in my previous trust in 20 years, to hear our last chair saying in his final AGM that I was the 15th chief exec in 20 years here. And that kind of instability and leadership does cause some real problems. It's not just the chief exec, of course, it's right through the senior leadership. And I've been delighted to bring in people like Dr. Mamta Vaidya, who's joined us as our chief medical officer, and Hepworth as director of strategy and partnerships. And shortly, our new Chief People Officer starting, more of which later, alongside some really experienced members of the team like Catherine Halford, Alan Wishart, Nick Swift and others who've been here for longer and know more about the trust, and of course then broader than that, our divisional leads. But really getting that top team in place has been critical. We've also been doing some work on our structure to reduce the number of different managerial units and silos we've got to work with and create a stronger sense of accountability and responsibility across the two hospitals. We'll shortly have a managing director for King George Hospital in recognition of the really important role that hospital plays in its local community and in the very bright future with all the developments that are happening on the King George site. And the next piece of work for us is to focus on our organisational strategy and values. And I'll say more about our culture shortly in the work we need to do around this, but really understanding, you know, what are we here to do in the context of the local population, working with our partners in BHRUT and primary care and elsewhere, and also working across North East London to really get to grips with some of the challenges that we're facing as we go into the winter and the years ahead. So there's those kind of key elements that have been a critical part of my role since I get here, getting the right team in place, getting the right structures to deliver. And now we've got those things there, really engaging with our organisational strategy and thinking about how we go forward in that context. Now, a really big part of what we're here to do, of course, though, is to make sure that patients get the right care. And you know, many of the people that use our trust services do have an excellent experience of care. You know, we're setting the pace regionally and nationally, actually, in terms of some of the high volume, low complexity work we're doing in surgery, which we'll hear more about later, and a number of our services where we're really innovating and really offering people some superb care and great experiences. And in some other areas where we've been challenged, such as maternity, we've recently had external peer visits and reviews where they've been happy with the progress that we're making and making sure that the many thousands of women who come here every year and give birth get the right kind of care and experience. But then there's, of course, the waits that people face in urgent and emergency care. And that really does cast a significant shadow over the rest of what we do as a trust, because it's a very visible part of what we deliver, and it's something that people who live in our boroughs experience. You know, they know someone who's been to one of our urgent treatment centres or EDs and waited longer than they should offer care, and so that's rightly been a big focus of ours. We have invested, as the chair said, in new emergency departments at King George, both for adults and children, and we've been doing some more work here at Queen's with more to follow on making sure we've got the right environment to care for people. But much more importantly, it's about getting the right flow through the hospital so that we don't have ambulance delays and we don't have those really long waits to be seen and be treated. And we know that at the minute, actually, Queen's and King George do stand out there in London and actually nationally in some cases in terms of the waits that people face when they come into the site. We have started to make some inroads into some of those areas now that we've started to get an understanding of what's going on. So we've started something in the last couple of weeks called Project Snowball in our emergency department at Queen's, where our older patients, the over 75s who are coming in, are not waiting in the emergency department anymore. They're being taken through to an hour from 7 a.m. to 7 p.m. into our frailty unit, irrespective of capacity. And what that's doing is sharing risk more fairly across the hospital. And we're going to start doing that in acute medicine shortly. And we're also looking at the partnerships that we've got and how they're really key to our success. Working with our GPs, working with our local authorities, working with London Ambulance to understand what we can do to support them and get ambulances offloaded and crews back on the road. And really making sure that actually we do the best that we can within the hospitals to do those things within our control. It's really striking that I'm here speaking to you today, and we actually have in Queen's over 90 patients in the hospital today who are medically fit in inpatient beds who are ready to go home. That far outweighs the number of people waiting for beds in the emergency department. Likewise, at King George, a smaller hospital, but still more than 30 patients there who are medically fit and ready to go home. Actually, if we can do some things within the system to look at people who are in the bed base and who don't need to be there, there's the capacity within our gift with our partners to really do much better in this. And as we've said, you know, we expect to be held to account for making these improvements. Our patients deserve better, and actually our staff deserve better than working in crowded environments where it's difficult to practice medicine. And so this year we've been getting to grips with some of those underlying challenges. We're starting to see positive signs in turning this around, and I hope that by next year's AGM we can start to show, in terms of the real progress we've made in performance, ambulance handovers and other areas, that the work we're doing as this new, more stable team is really starting to get to grips with some of these really significant problems. So next slide, please. All this is in the context of, as anyone who reads the papers will be aware, a really tough financial context for the NHS. We as an organisation currently spend about £6.5 million a month more than we can afford to. A big driver for that is the money that we spend on bank and agency staff. So these are staff over and above our permanent members of staff. Some of them are our permanent members of staff doing extra shifts, typically at a higher rate than we pay our full-time staff, but that's causing us some really significant cost pressures. There's a range of other things we can do, looking at the amount of money that we spend on medicines, the amount of money we spend on diagnostic tests and how often we do those, how we procure things, how we buy things in for the NHS and get value for money, and how do we get best out of our estates. But there's no denying the fact that as we go into what's going to be a difficult winter, we're also going to have to make some difficult choices about where we spend money and where we save money so that we get back closer to living within our means. And that has become a really big focus for the team at the minute. You know, within the NHS, we've had a period in COVID where there was extra money pouring into the service to focus on one specific clinical priority. But now we've come through that. We've got a backlog of people who've been waiting for care. Many of them are sicker than we were before. And what we've got to do is deal with that, deal with increased emergency demand in the context of a shrinking workforce and try and get that very best value for money out of that. All that together makes for a tough set of challenges, actually, but it's great to see the leadership team across the trust and working with our partners in the system really coming together around that. And of course, supporting some of this through our collaboration with Barts Health. And we've been working with Barts to look at things like the fact that we're the last acute trust in London that still relies on paper for patient records. Actually, a really good opportunity there to work together with Barts to bring in an electronic patient record, which will improve both the quality and safety of the care we deliver, but also reduce some of the bureaucratic waste that there is around patient processes, and also encourage staff to come here. You know, because people who are used to working in digital hospitals these days, when they come here, actually, it's like stepping back in time. Great opportunity to collaborate with Barts around that, and also to manage the workforce market in North East London. We've got 3 trusts in North East London, all of whom are competing for a smaller and smaller pool of staff. And actually, if we end up in a bidding war with each other around workforce, that doesn't help any of us. Actually, we're looking at how we create good quality, sustainable career pathways within Barts and BHRUT to really support people to come to North East London to work for the NHS and stay here. So there's some really big opportunities there between the trust working together to get to grips with some of these drivers of our financial deficit. And then the last area I really want to talk about is about staff morale and culture. And it's been an interesting few years for the NHS, where it's gone from the sort of Thursday night clapping and the recognition of the huge efforts that the service made to save lives during the pandemic to a very different set of public sentiment about the health service now, where people feel as though they can't get to see their GP, even though GPs in North East London are seeing more patients than before the pandemic. They're busier than ever before, but it's becoming harder and harder for people sometimes to get appointments, where they can see actually the ambulance response times are being eroded because of the level of demand, and actually where they know it's getting harder to get the surgery that you need or the emergency care that you need. And actually in that context, we're really having to look at what we do to support our staff during these difficult times. And actually an important part of that is morale, but also the culture of the organisation, the way we do it. And we know from our staff survey, actually, that there's more we need to do to improve the experience of working here. We've got a new Chief People Officer joining us from NHS England in a couple of weeks' time. She'll be with us in November. A woman called Janine LaRosa, who's very experienced in the sphere of working around equality, diversity and inclusion, and actually brings some really good skills both from the NHS and also from the private sector. And she'll be really helping us get to grips with some of this culture stuff, working with Alan Wisher, our Director of Workforce. And actually in that, we need to focus specifically on some of the stuff our staff are telling us. Too many of them experiencing racism in the workplace, whether that's from colleagues or actually from patients as well. It's a depressingly familiar story from some of our staff where they've been asked by patients that they want to see a white doctor or a white nurse, and we need to move away from that and start actively challenging that, as well as challenging one another when we hear people using language that isn't appropriate about people's race. We also need to address sexism as well, and it's come through, you know, in our recent junior doctor survey and also in our staff survey, that too many of the women who work in the organisation do not get treated fairly and don't get the respect they deserve from male colleagues as well. And so these issues around culture, what we define as acceptable in the organisation, are really important for us as a good employer and as one that wants to attract and retain the very best people. So you'll see a lot more of that being picked up in the organisation this year. Cost of living is causing a lot of pressure on us. You can see photos there actually of the thank you day that we had earlier this year, just to say thank you to our staff and to give them the opportunity to get out and enjoy themselves. But also a photo there of the school uniform exchange we did to recognise actually that the cost of living pressures, increasing fuel costs, heating, what you can do to get around and look after your family. This stuff's all hitting our staff. And it's informing choices, particularly at the lower paid end of the scale, about where people work, whether they stay with the NHS or go elsewhere. So we've been trying to take action to encourage people to feel supported as we go through these difficult times with inflation rising and prices going up. And also around wellbeing support, helping people deal with the pressures that creates in their private life and deal with the pressures that they sometimes bring to work. And as I said, saying thank you is a really important part of that. And sometimes in all the hard stuff we're having to do, it's easy to forget all the great things that we do as well. And it's really important as the leadership of the organisation, we take that time to recognise the fantastic efforts people make day in, day out around here. So many of our staff work here, but also live locally. And it's their family and their friends that come into the organisation. And actually for the challenges that we have and the tales where people haven't got the care they need, we also hear from so many people how our hospitals have made a real life-changing positive difference to the experience of people that do depend on us. And finally, the last thing I just want to mention is workplace. Although we might not be digital in terms of our electronic patient record, we are shortly going to be launching a new communication tool right across the trust to try to bring all of our staff together in a way that allows us to communicate with them in a much more active way. I think for the staff, they'll be excited about that. For those of you that are involved with us through the board, you'll be excited about that. That is going to be another really big plank of taking our culture forward in a way that represents our staff base in a more effective way, that tackles some of these insidious problems and makes this a better, happier place in which to work and be cared for. So there's plenty for us to get our teeth into. I have to say there's a fantastic team that we've managed to attract to the trust and to retain some great people. And actually, as you'll hear from some of our clinical leads and our operational leads in the course of their presentations, there's real strength and depth in this place and a real passion to do better for our patients. It's a privilege to be the chief exec of this organisation. I'm very happy to be here and very much looking to what we can achieve together over the years ahead. Thank you, Chair.
Thank you, Matthew. Very encouraging and clear both about the progress that we've made and also some of the challenges that we have to come. We're now going to hear from Shane as the Group Chief Executive Officer about the collaboration work, some of that partnership that I was talking about earlier on. So Shane, over to you. Thank you.
Yeah, thank you, Chair. Good evening, or good afternoon, everyone. Delighted to be here as the inaugural Group Chief Executive between BHRUT and Barts Health. I'll just talk for a couple of minutes on the collaboration work and the partnership piece that are going on across the system. So just firstly, in terms of the work we're doing with our fellow hospitals, and a lot of this came from collaboration during the pandemic, where there's 7 hospitals across North East London, so the hospitals at BHRUT, hospitals in Barts Health and the Homerton worked very much closely together around making life easier for patients and for staff. And we've tried to kind of capture the essence of that as we look forward to what we're calling an acute provider collaboration. And you can see the picture there about the different boroughs in North East London. So this is also about working with hospitals allowed to work in their own local borough, the so-called place, to make sure things are working that suits the local population, but that we also work across boroughs and across hospitals to get the best for patients. Very much trying to get into the space of tackling inequalities, access, making it easier for patients and more timely, better patient outcomes, and applying mutual aid between hospitals to ensure we not only drive up patient experience, patient access, but also better value for the taxpayer in terms of how we spend several £billion of taxpayers' money in North East London on acute hospital care. So the Acute Hospital Collaborative, which is essentially, as I say, the BHRT hospitals, Barts Health and the Homerton, will work on a number of initiatives going into the next year, but it's very much born out of the good work we did during the pandemic. And as Jackie's mentioned in her opening, connecting this to the integrated care system, to making sure that we're working with other colleagues in primary care, community social care services, mental health, etc. Next slide, please. So if I just turn to the specifics of the kind of closer collaboration between BHRUT and Barts Health, look, this is under making really good progress now. There's some kind of structural pieces. Obviously, we've got Jackie here, almost coming up to almost a year as the joint chair. We've got a group CEO now in post, myself, several joint non-executive directors, and an exchange of senior leaders across the organisations. And we captured a number of this in our memorandum of understanding, which we published earlier. There's been some actual tangible benefits thus far. So a number of Bart's Health patients, nearly 5,000, being treated across at BHRT, particularly for diagnostic scans and procedures. And then some collaboration around the recruitment to kidney doctors, just to make sure we can help fill some long-standing vacancies and get patients better access to treatment. So that's probably just a couple of specific examples, but we're clearly looking to work a lot faster around shared learning to reduce waits across a number of our specialties, and really working on joint solutions that enable both organisations to become far more clinically and financially sustainable. So within the work streams this year, we're going to focus on a few things, really firstly around urgent and emergency care. And Matthew's talked about some of the challenges facing Queen's and in George's. Well, there are challenges right across the NHS, across London, so there's something to collaborate on around urgent emergency care. On planned care, we'll continue to work together to reduce the waits for patients, to make sure we can drive down that backlog that arose during the pandemic. We want to collaborate on workforce, because there are clearly, workforce is the #1 challenge facing all the hospitals at the moment across North East London. So any way we can work together to reduce our reliance on temporary agency staff, get more substantive staff into the system, that will definitely help what we're doing for staff and for patients. There's something about how we're organised, sort of governance and organisational development, pieces that can continue behind the scenes. And Matthew's touched on a real opportunity, I think, to help that sort of digital transformation that we can do across BHRT, based on some of the experience of Bart's Health, with some external investment coming to support that, which I think will be fantastic. And then clearly we touched on finances behind the scenes. We want to work a lot on how can we get better value for money across the two trusts and support that money going into patient care. So quite a lot going on in the collaborative space. Like Matthew, I'm kind of delighted to be in the role that I'm in, and I'm really looking forward to continuing that collaboration. Thank you, Chair, back to you.
Thank you for that, Shane. Once again, some encouraging opportunities, as I spelt out at the beginning, in terms of the way that the two trusts are working together. And I'm constantly finding, when I go out and meet staff in both trusts, that they talk to me about the ways in which they are linking up. So this is not something that is only driven from the top, but something where staff are really finding the opportunities of working together. I want to move on now to the financial outcome for 2021-22 and the financial outlook for 2022-23. And presenting that will be Nick, our Chief Finance Officer. Just a reminder, if you have questions that you would like to ask, you can put them in the chat, which you can get to by going to the speech bubble at the bottom of your page. Thank you, Nick. Over to you.
Right, thank you, Chair, and good afternoon, everyone. Slightly disappointed not to see a photo of myself on this slide, but never mind. Let's move on. I'll get over it. So three slides from me, please. Last year was difficult, as others have described, but we did make some good progress. And as you see on that bottom right-hand table, under the 21-22 column, we did come in pretty much bang on target, a small £500,000 loss, but that was a really good result. So big thanks to all colleagues for getting us to that position. And importantly, a bit further up in the box there, we paid 92% of our suppliers within 30 days. We're an important part of the local economy, and it was nice to have enough cash to keep our suppliers in good shape. On the next slide, please. As there's also been mentioned, we're getting a lot more capital to invest for our patients and population. It used to be about £7 million a year. In the last 3 years, we've invested over 120 million, which is a big vote of confidence and a recognition in the needs of our population. And here are some examples of how we've invested that money. And we'd hope to maintain that sort of run rate over the next 2 to 3 years, not least because of some of the digital opportunities that Shane has mentioned. And next slide, please. And so when we look forward to this year, things are getting more difficult. And what this chart shows is how we're trying to save money so that we don't end up in that red zone, but get ourselves in the amber and green zone. And what that means is making losses for this year, because it is more difficult, of no more than 30 million. If you look down that March sort of y-axis, you'll see the 30 million is the edge of the amber. And as Matthew says, what that means is we need to save at least 20 million pounds. We haven't had a particularly quick start, but we are now starting to build momentum, which is terrific. And the three areas we're aiming at is temporary staff, other areas where typically we've been spending money on COVID-related activities that we don't have to now. And then thirdly, the elective capacity. And just touching a bit more on that first one, the issue with temporary staff is we can end up with quite significant workforce inequalities, where two colleagues working next to each other are paid significantly different amounts of money. And that's just not a good, sustainable position to be in. And as we correct that and get more and more substantive staff and reduce that extra cost, particularly in areas like off-framework agency, which we really do need to stop very soon, that means we have more money to address population health inequalities, which is exactly where we want to spend the money. So pleased with progress that we're building there. And then obviously the more we can do to reduce waiting lists by increasing activity, broadly speaking, the more money we get through elective recovery fund, and colleagues will talk about that. But that's a really important area. So it's not easy this year, but I do think now we should be confident we can get into that green or amber zone by the end of the year. Thanks very much.
Thank you, Nick. Now it's been pointed out to me, sorry, that if you're thinking of asking a question, that your chat icon may actually be in the top right-hand corner of your screen. Wherever it is, it's shaped like a little speech bubble. So sorry if that was a bit unclear. Let's now move on to some of those clinical presentations that I was talking about earlier. And Amalesh, I think you're going to introduce your team and the two presentations that we have today. Thank you very much.
Thank you, Chair. As you rightly pointed out, the pandemic had a huge hit on NHS as general, but certainly from the elective provision we were providing, where the backlog was increasing even pre-pandemic, but the pandemic really shook it up a huge notch, which meant that when I talk about elective care, just to make people a little bit aware of what that means is, we are really talking about outpatient appointment, we're talking about the scans and the diagnostic tests that we need to do, and we're talking about the treatment opportunities that includes operations or like. So this is the elective care that we are talking about, and that has taken a huge hit for about 18 months and put a massive dent into what we normally would like to achieve. However, the teams have really responded to the challenge in a much more positive way than potentially many places across the country. When I talk about our team, I'm talking about right from the front end, the clinicians and nurses, the allied health professionals, right down to our managers, our admin staff, the people who support, the enablers. So all of them have had a sort of been really focused on how do we make interactions of patient with either the provider, the clinician, or with the diagnostic center with data much more seamless and much more easier to get to. We as a division, as departments, have done multiple projects to help with this. We're going to showcase two of them to see what we have done, but this is run across multiple specialties. And what I'm particularly proud about of all these things that we've done is it's all been purely based upon patient care. In other words, really getting the numbers down, really interact with the patients, getting those patients seen early. So all the projects that we've done have been focused on getting the patients seen and getting the patients treated. Also, what this has done is not only had a dent on many of the patients' backlog, it also helped us realize what are the things that we can do better, what are the things we can innovate, what are the things that we can do much more seamlessly and actually make a much more bigger impact across for a longer duration. So just not now, here and now, but also on a longer duration. So first we will have the Gastronaught project, and they will introduce themselves, and then we'll go to the next project. Over to you, Sarah Jane.
Hello, good afternoon, everyone. My name is Sarah Jane Moore, and I'm the Deputy Service Manager for the Gastroenterology and Endoscopy Department here at BHRUT, Queen's Hospital. So this afternoon, I am going to be talking to everyone about the Gastronaught project that we did at the back end of last year, 2021. There may be some terminology that I'm using that may not be understood. I will go through and try to explain everything as simply as I can, but if anyone does have any questions, please pop them in the chat box, and then I will get to them at the end, if that's all right. Next slide, please. Right, so the drive behind our Gastronaught project, as it has already been previously explained, unfortunately, due to the pandemic, lots of departments across not just our hospital, but other hospitals across London and the rest of the country did develop a backlog of patients, whether that's outpatients or diagnostics, all sorts. Within gastroenterology, we developed a backlog of patients waiting for their first outpatient appointment. We was tasked with this project to try to reduce this as much as we can by our divisional director, Mr. Amalesh. We agreed that the best way to achieve this was as a team. So it was time for us to put our heads together and get creative, and that included the name as well. Next slide, please. So as you can see on here, I'm not sure if you can see it clearly, but once we got together as a team, we had a brainstorming afternoon. You can see all of our brainstorming ideas on the slide attached. So I want to talk about the Gastronaught project title first. So we got together one afternoon and thought, how are we going to achieve this together, and how are we going to stand out? Some ideas were thrown in, such as the Gastronaught project, gut clinics, Gastronaught week. And in the end, we decided that actually we were going to go with Gastronaught. One, because we are the gastroenterology department, but also we wanted to set ourselves an ambitious aim of getting our backlog down to naught, hence Gastronaught. So once we've done all the brainstorming ideas, we had to think, okay, we need to ensure resources were available, not just within the gastroenterology and endoscopy department, but also across the other support services, because bringing patients in for their first outpatient appointment doesn't just affect us. It affects other departments such as histology, radiology, and of course the outpatients department. We worked alongside those departments to ensure that they were aware of the project that we were doing and that they could help provide the extra capacity that may be required. Now, the Gastronaught project, the idea behind it was that because we had a backlog of patients, the doctors were going to clinically triage all of the referrals that we had in our backlog. As change could be a little bit difficult for some people, we decided, okay, let's not just thrust this new job onto our clinical team. We went and sat with the doctors, showed them exactly how the triaging works. Now, triaging is reviewing referrals to see what the best course of action would be for that particular patient. That could be see the patient in face-to-face clinic. That could be doing a telephone consultation instead, or sending a patient straight to test. So we set up these training sessions, showed them exactly what they needed to do, but not just because we weren't just going to train them and then off we go. We wanted to work collaboratively with our clinical team. So we had the clinical team and the admin team working together to ensure that we, one, achieved our ambitious aim, but also to make sure that the patients got the best possible care via this new pathway. So we had to have a look and go, okay, we had a look at our doctors' timetables and job plans and thought, can we include this in their current working timetable? That wasn't possible. So we had a look and thought we need to use our resources a little bit differently. So we've got consultants and clinical doctors that do outpatient clinics, and we've also got consultants that do endoscopy lists and some that do both. So instead of moving one problem from, say, gastro to endoscopy, we decided, hang on a minute, why don't we try to optimise our endoscopy service as well? So instead of just removing a doctor from an endoscopy list and leaving the list to go unfilled, we thought, let's move the doctor to do the triaging, and then we can put a nurse endoscopist into that endoscopy list. So both services were still running at an optimal level to be able to provide excellent patient care. Now, as the NHS, we do try to work as efficiently as possible. So we was able to do that by changing the timetable for the doctors for those couple of weeks ever so slightly. We needed to set out a timetable. As I say, because we had to change the doctors' timetables a little bit, we wanted to ensure that everyone knew exactly where they needed to be, what they were tasked with, so we could be able to do this. What we did was we sat with our clinical team, first of all, when they first started the triaging. We let them move forward with it on their own. And then there was one particular doctor that I would like to point out. He was tasked with a set number of patients. Then when I went back to go to see how he was getting on, he had done an excellent job and actually surpassed the quota that he was meant to have triaged, and triaged a lot more. And he found it, in his words, very addictive. What he thought, and the positive comments I also got back from him, was he actually enjoyed doing the triaging, because what we've found as well in the department is that not everyone can come to a face-to-face appointment. We have obviously within our remit, we have patients who work full-time. We have patients who have children who might have childcare issues. So we was able to try and tailor some of our appointments around the age range and stuff, and other demographics that we have for our patients. But what he also liked as well was that if a patient didn't need to come in for a face-to-face appointment, he thought, let's send them straight to test, because if we do that, we can take out the first appointment where they would have to say take time off work and then have to take time off work again for an endoscopy appointment or a radiology appointment. So it made the patient's pathway a lot quicker and a lot smoother. Next slide, please. Right, going to setting our ambition. So first of all, we thought, okay, let's set an ambition or an aim of reducing our backlog by 250 patients. We had that in our mind. Being a very ambitious department, we wanted to try and bypass that, apologies. But in able to be able to do that, we had to become, as I call us, the dream team. We wasn't able to just rely on our clinicians to do that. We couldn't just rely on our admin team to do that. We had to work together. And that ranges from clinical leads, clinical consultants, clinical endoscopists, we had nurses, we had the receptionists. Every part of our team was included in this success. Next slide, please. So, what was our success? It was an overwhelming success, as you can see from the slides. Our aim was to have triaged 250 patients and reduce that backlog by that way. No, we managed to triage 636 patients, which cleared our ASI list down to 0. And some of the outcomes of this was that, let's have a look, 4% of our patients got their care a lot quicker, whether that was by being sent straight, because that was being sent for a straight test. So then they didn't have to come in for their first outpatient appointment. 30% of those patients were discharged straight away as they didn't need to be seen. They didn't need to be seen in a acute hospital setting, but we didn't just send the patients on their way. All of the patients were advised appropriately, and the GPs were advised appropriately as well to be able to manage the condition at the GP rather than in an acute hospital setting. 10% of those patients as well were referred to the appropriate service. We did come across a few patients that were sitting in our backlog, but actually they needed to be seen by other departments such as gynae. And we ensured that once they had been triaged by ourselves, we contacted the gynae department, let them know, and then patients got actioned quickly. And we're still going very strong today. So during that week, during those 2 weeks of our Gastronaught project, the first week was to get all the triaging done. Let's work out exactly how many patients need to be seen. How many patients need to be seen face to face? How many need to be seen in a telephone clinic? And the extra capacity that we managed to put in by changing their job plans ever so slightly, we managed to see all of those patients in that second week as well. Now, the target for the first outpatient appointment is 6 weeks. I can confidently say that we have no ASI patients waiting for their first outpatient appointment, and all of our patients are currently being seen within 4 to 5 weeks of their referral being received. So we had an amazing success, and congratulations to our entire team. As I said, we couldn't have just done this with 1 or 2 people. It was a great team effort. Thank you. If anyone has any questions, please pop it in the chat box or put your hand up. I'm more than happy to answer any. Thank you.
Thank you. Thanks, Sarah. One bit about the team is they're just fantastic. They came together. The challenge did not daunt them, and they've continued to sustain the change and the benefit that they've had throughout, and they continue to do it. As Sarah just pointed out about a clinician, and when it's really telling when the clinicians and the support that they received from the admin and clerical just made a huge transformation for how they felt. And both of them, the admin clerical felt valued, the consultants felt valued, and all of a sudden it just brought the magic in. Thank you for that. And over to Ayman and his team. We got it. Thank you.
Thank you, and good afternoon, everybody. Thank you for the opportunity to present to you. In ophthalmology, our project was called the Pr-EYE-ority project, and there is a reason for that. But the idea is that, as you have heard, there was quite a bit of challenge that was thrown to us by COVID and by the changes that was brought with that. And in order to respond, we had a backlog of patients that we needed to see, but also we focused on building a team and sort of that is cohesive and responsive in a way that can deal with these pressures going forward. So I'm going to hand over to our lead nurse, Adi, who will talk a little bit about the Pr-EYE-ority project and how did it come to life.
Thank you, everyone. My name is Ade. I'm the lead nurse for ophthalmology. I'm just going to take it from the previous slide. Like Ms. Kaya just said earlier, as a result of the COVID pandemic, we lost, and also prior to the COVID pandemic as well, we lost slot at Brentwood, and also we reduced capacity in theatre as a result of COVID. That was just quite timely at the same time, just about a few months apart. So overall, we lost about 130 to theatre and about 100 clinical slots. We lost that to COVID. So, and then this brought about the Pr-EYE project. How do we resolve this problem? How do we combat the backlog as a result of that? So because of the capacity issue as well. So next slide, please. So we involved all of the staff in finding solution to our own problem. So because we all understood the issues at hand, and then as a part of the solution, what do we come about solution jointly and together, knowing very well that everyone will be involved and part of the team, because this is a problem that we are quite familiar with, but not to the extent of the effect of the COVID. I'm sure you'll all agree with me. So what we did, we looked at all of the subspecialty, and probably, if I'm not mistaken, ophthalmology will probably be the biggest specialty with so many subspecialty in the trust. So we looked at each of the risk in the subspecialty. We stratified all of the risk. Because some of our specialty, they are very time sensitive, like glaucoma, medical retina, pediatrics. So we looked at all of those big specialty. We looked at the risk. Some of them are less risky, and some of them, they are priority are high risk. So those that are high risk, we continue seeing them on site, and then those who are like less risk, we refer them to the community so that the patient could be seen. So at the end of the day, we looked at a visual aid production board to continue to monitor this progress. So that will take us to the next slide, please. I'll hand you over to Sister Rebecca.
Next slide, please.
Yep, so I'm Rebecca. I'm one of the sisters in ophthalmology. So all the patients throughout the time were sent appointment letters and text reminders. They were staggered appointments to help reduce with crowding issues and to maintain physical distancing with additional seating throughout the department. We've tried to maintain better use of space to create additional areas for vision checks, diagnostics, and additional equipment. And we've looked at adjusting timetables to optimise use of resources within the department. We've got regular weekend activities going on for a lot of our subspecialties for glaucoma, diabetes, macular degeneration, which are our three largest groups within the department, and leading to high volume weeks, managing as many patients as possible with super weeks within the department as well. I'll hand you back to Mr. B.
Thank you. Next slide, please. So as you heard, we were trying to find a way to manage our backlog of patients. We've done a bit of work about team building, and I'm with the help from our people development team within the trust. And you saw how we approached that to create the process to see these patients and how we designed it. So as a result, we have so far done 7 high volume weeks. So the first week was a trial. We didn't know how successful we were going to be. Our usual weekly average is to see 450 patients. And when we did our first week, we were able to see 560 patients. After that, we became slightly more bold. So we held 6 additional weeks, and in total, we saw 4,637 patients, which is almost the entire size of our PTL. We did a dedicated, which is the backlog of patients that we need to see in any particular time. We did a dedicated week for children, and usually our weekly average is to see 65 children. In that week, we saw 326. You heard about some of the changes we made in our department. We know that in our department, patients wait a lot to have their visual acuity check and to have some diagnostics before coming to see the doctor. And by changing the patient journey within the department, we were able to halve the time that the patient spends in our clinic before seeing the patient. It used to be about 40 minutes, 35 minutes, and now we dropped it down to anything between 15 to 17 minutes. So we continue to do this work. Last week, we did our seventh priority week, super week. Our target was to see 800 patients, but actually in the end, we saw 1,153 patients, which was really magnificent result. And now we also have another project. We think we are going to call it Bright Eyes. We're aiming to see 1,000 children over 3 months in dedicated clinics. And we are now into week number 3. We continue with this work, and I will be happy to feed back to you when that is done. Thank you very much.
Thank you. Ophthalmology team have been working hard. This is just not the one bit. They also do a lot of work on theatres. And just to highlight something that is happening currently since pediatric ophthalmology came up, in pediatric ENT, we've had one of the issues that we've had was a pediatric backlog and a pediatric ENT backlog. We had about 1,500 patients. In the last 3 months, it's just ongoing, but we are quite confident. It was a 12-week project to get it down from 1,500 to 150. And so that will be a significant help for our patients. These are children, and it's important that hearing is protected. So that's a part of it. And a couple of things just to highlight this bit. We have been shortlisted for a national award for elective recovery, which we are really proud about. And as I said, this is just not to departments. This is spread across all our departments, and we're really proud about the department, the staff, the workforce, and how focused they are. We were described in the Health Select Committee as an exemplar and things that for other trusts and NHS to follow. So we're really proud about it, and thank you. What do you think?
Good. Amalesh, thank you very much to you and your teams. As you say, this is enormously encouraging work, and we've also, of course, heard that it's a success that comes from all the staff involved, both in and supporting the teams, being involved and working together. So thank you very much to you and the teams for that very encouraging progress. Now, we don't have any questions from the public. Of course, the annual general meeting is the opportunity for the public to hear about the work that we've been doing and our plans for the future. But what we will be doing is placing the recording of the presentations that we've done this evening onto the internet so that people are able to see it. And then if members of the public have got questions or issues that they would like to raise with us, obviously there will then be the opportunity. So given that, and I don't see any member of the public raising their hand or any other questions. So I'm going to draw the AGM to a conclusion. Thank you very much to everybody for your contributions and some of the very encouraging hard work that we've seen demonstrated in this evening. Thank you, everybody. And as I said yesterday, have a safe journey home, even if it's only to go and get a cup of tea from the kitchen. Thanks, and see you all soon. Thank you.